Okay, so can everyone write down the diagnosis for the ECG in the chat? Yeah, can you hear me? Can anyone hear me?
Yeah, we can hear you.
Okay. So did everyone see the ECG or do you need to see it again? Okay, so this is an ECG showing ST elevation in the anterior chest leads from V1 to V4 and ST elevation in leads 1 and AVL. So these are the anterior and lateral chest leads. So this is anterolateral ST elevation myocardial infarction. I'll remind you of the how to localize ST elevation myocardial infarction. From V1 leads, chest leads V1 to V4. These are the anterior chest leads. V5 and V6 and 1 and AVL are lateral leads, and leads 2, 3, and AVF are inferior leads. So if we had ST elevation in leads 2, 3, and AVF, this would be inferior STEMI. In this case, we have ST elevation from V1 to V4 and 1 and AVL. So this is anterolateral STEMI. The question could come as what is the diagnosis for this case? And we can also ask you about the immediate management. So the immediate management in this case would be coronary revascularization, primary percutaneous coronary intervention, and coronary revascularization. Okay, so this is the next ECG. Can anyone tell me what this ECG shows? Okay, so this ECG it's a rhythm strip. It's not a 12 lead ECG like this one. This one is a 12 lead ECG. This is only a rhythm strip. We can only see one lead. We have a P wave for every QRS, but it's very close to the T wave, like in this in this strip ECG. We can see the arrow pointing at the P wave. So the P wave is close to the T wave. PR interval is prolonged. This is something called first degree heart block. So these two ECGs are first degree heart block. The normal PR interval should be around 5 small squares, which is around 200 milliseconds. Here it's around 2 large squares, which is around 400 milliseconds. So this is an extremely prolonged PR interval in both in this ECG and this ECG, as we can see. As I said, the arrow with the P above it pointing to the P wave. It's the PR interval is prolonged, with the P wave almost buried in the T wave. Okay. So this is the next ECG. Can everyone see the ECG? But the previous ECGs, we had something called first degree heart block. In this ECG, as we can see, the atrial rate is different from the ventricular rate. As we can see in the two rhythm strips below the 12 lead ECG, we have a higher atrial rate than the ventricular rate, and this is a bradycardia. This is something called complete VA or ventricular atrial dissociation. The atrial rate is completely different from the ventricular rate. So this is something called complete heart block or third degree AV block. I'll focus on the rhythm strip leads. As we can see here, the P waves and the QRS waves are completely dissociated. They are not at the same rate. We can see around 2 to 3 P waves before every QRS, and they're not at the same rate at all. If you are asked about immediate management for this kind of case, it will be a temporary pacemaker insertion, temporary pacing. So immediate life-saving management in a case of complete heart block is temporary pacing. This is another ECG showing complete heart block. As we can see, the P waves are at a rate different than the QRS rate. So the atrial rate is completely different from the ventricular rate, and they're completely dissociated. There is no relation between the P wave and the QRS wave. So this is complete heart block or third degree AV block. And the immediate management will be temporary pacing. Okay, this is our next ECG. As we mentioned before, when we mentioned our algorithm, we will be checking the heart rate to see if the patient is tachycardic or bradycardic, and we also be checking the rhythm, whether it's regular or irregular. As we can see here, this rhythm is completely irregular. There are no P waves. So when we have no P waves and the rhythm is completely irregular, this is atrial fibrillation. So this 12 lead ECG shows atrial fibrillation. It's completely irregular. There are no P waves. We can see in the rhythm strip below, there are fibrillatory waves, which occurs with atrial fibrillation. This is our next ECG. So this is a patient presenting with palpitations. His blood pressure is 70/40. So first, we will check the heart rate. This is a very high heart rate, above 200. So this is a tachycardia. Next, we will check whether it's the QRS complex is wide or narrow. In this case, the QRS complex is very wide. So we can see here, the QRS complex is around 4 to 5 squares, which is around 160 to 200 milliseconds. Our normal QRS complex is from 80 to 100 milliseconds. So this is a wide complex QRS, wide QRS complex. So when we have a tachycardia with wide QRS complex, this is ventricular tachycardia. So this ECG shows ventricular tachycardia. It's very important to know the immediate management in this case. As I mentioned, the patient has low blood pressure, 70/40. So in this case, the immediate management would be DC, electrical cardioversion. Okay. So this is ventricular tachycardia. Heart rate is above 110. It's around 200, in the 200s. QRS complex is wide, so it's a wide complex tachycardia. This translates into ventricular tachycardia. Okay, next, this ECG. Heart rate is around 105, 110. But the ECG is narrow complex here. So this is a narrow complex tachycardia at a not very high heart rate. We'll check for the P waves. As we can see here in lead 2, there is a P wave before every QRS complex. The P wave is positive in lead 2 and negative in AVR, as we can see here. So this is a narrow complex tachycardia with a P to QRS ratio of 1 to 1. So this case is a case of sinus tachycardia. So this is sinus tachycardia. Okay, to our last ECG. This is also a tachycardia. Heart rate is around 160. We'll check the QRS complex to see if it's narrow or wide. As we can see, the QRS complex here is very narrow. It's around 80 milliseconds. So this is a narrow complex tachycardia. We can't see any P waves, unlike the previous ECG here. Here we can see P wave before every QRS complex. Here we can't see any P waves at all. So when we have a narrow complex tachycardia without P waves, this is something called SVT. Diagnosis is SVT. Does anyone have any questions?
Yeah. How do you distinguish if it is atrial tachycardia?
Okay, so atrial tachycardia will be similar to the sinus tachycardia ECG. There will be a P wave before every QRS complex, but the P wave will be different in morphology. As I said in the sinus tachycardia ECG, the P wave was positive in lead 2 and negative in lead AVR. This is the typical for the sinus tachycardia. In atrial tachycardia, it will have a different morphology. It may be negative in lead 2 and positive in AVR. So this is an easier way to differentiate atrial tachycardia from sinus tachycardia, but it will be a difficult ECG. So it's not usual to give you a case of an ECG of atrial tachycardia.
In sinus tachycardia, the P wave will be positive in AVR and negative in which one?
In sinus tachycardia, it will be positive in lead 2 positive, and negative in AVR. In
Okay,
atrial
thanks.
tachycardia, it might be different. So in atrial tachycardia, if you find the P wave is negative in lead 2 and positive in AVR, this is probably atrial tachycardia. Do you have any other questions?
And when it is narrow QRS complex tachycardia, what type is it?
So narrow complex tachycardia, if you see no P waves and it's regular, this is SVT. If you see no P waves and it's completely irregular, as we said, it's atrial fibrillation. I'll show you the ECGs again. So here, this is regular narrow complex tachycardia. So this is SVT. No P waves, regular, and narrow complex tachycardia. Here, it's narrow complex tachycardia, but it's irregular, and we have no P waves. Since it's irregular and no P waves, this is atrial fibrillation. Here, it's a narrow complex tachycardia, but it's regular, and we have P waves before every QRS complex, positive in lead 2 and negative in lead AVR. So this is sinus tachycardia. Okay.
So all that we have is ventricular tachycardia, atrial fibrillation, SVT, and sinus tachycardia. Only these four?
Yes, and the tachycardias. Yes.
Okay, thank you.
You're welcome. Any other questions? Does anyone want to see any of the ECGs again? About the PDF or the presentation, I will ask the staff member who is in charge of the teaching if they can send it to you. Okay, so we don't have any more questions? So the important ECGs we showed today: anterior STEMI, ST elevation in the chest leads from V1 to V4 and 1 and AVL, so it was anterolateral STEMI. If there was ST elevation in the inferior leads, it would have been inferior STEMI. Immediate management is coronary revascularization. We also showed ECGs showing first degree heart block and ECGs showing complete heart block. Complete heart block, the immediate management was temporary pacing. And then we showed the ECGs showing tachycardias, as we mentioned. Wide complex tachycardia is VT. Regular narrow complex tachycardia with P waves is sinus tachycardia. Without P waves, it's SVT. And irregular narrow complex tachycardia without P waves is atrial fibrillation.
Do we only have tachycardia for the clinicals, or do we have anything else as well?
No, as I said, we showed other ECGs. The ECG for STEMI, anterior STEMI, I'll show it again. So this is the ECG for anterior STEMI, ST elevation in the anterior leads. Also with mild ST elevation in leads 1 and AVL. So this is anterolateral STEMI. The immediate management would be coronary revascularization. And then we showed these two ECGs. So we can see here at the point of the arrow is pointing to. This is the P wave. The PR interval is prolonged, and the P wave is just next to the T wave. The normal PR interval is around less than 200 milliseconds. This P wave is around 400 milliseconds. So this is first degree heart block. And then we showed these ECGs showing complete heart block, complete VA dissociation, as we can see here. The P waves are at or the atrial rate is completely different from the rate of the QRS complexes or the ventricular rate. And then we discussed the ECGs showing the tachycardia, as we mentioned right now.
Okay, thank you, doctor.
You're welcome. Okay, so we're done now. Good luck with the exam, inshallah.
Thank you, doctor. Assalam.
You're welcome. Assalam.
Doctor, are we only going to have these diseases in the exam?
I'm not sure actually about which ECGs will come in the exam, but I will ask the staff member in charge of the exam to inform you if they will only be the only ECGs coming in the exam. Okay.
Okay, thank you, doctor.
You're welcome.